Hi, I am Dr. Neurosurgery Greenberg, and we are continuing with pituitary tumors. Today, we are looking at differential diagnosis of an elevated prolactin, that is also called hyperprolactinemia. As in the table, you can see it may be due to pregnancy. In pregnancy, the levels are 10 to 400 nanograms per ml. It may be postpartum, and prolactin decreases up to 50%, approximately 100 nanograms per ml in the first week postpartum, and it is usually back to normal within 3 weeks. And if the female is lactating, then suckling increases prolactin, which is critical for lactogenesis. And once, as we know, that within 3 weeks the prolactin level is going to normalize, and if lactation has been initiated, then these non-pregnant prolactin levels can maintain the lactation. In the first 2 to 3 months postpartum, the basal prolactin level is 40 to 50 nanogram per ml, but suckling increases it 10 to 20 times. In the 3 to 6 month period postpartum, basal prolactin levels become normal or slightly elevated and double with suckling. And prolactin should normalize by 6 months after weaning. When solids start, then the prolactin levels come to normal levels. In the case of an adenoma, the prolactinoma, a larger prolactin microadenoma or macroadenoma will usually produce prolactin more than 100 nanogram per ml. But if there is Stolk effect, as we said, then we follow the rule of thumb, and by now hopefully you will have remembered it. That is, the percent chance of an elevated prolactin being due to a prolactinoma is equal to 1/2 of the prolactin. That is, if the prolactin level is 200, then it is 100% chance that it is a prolactinoma, that is leading to a prolactin high level in the blood. Then some tumors secrete both prolactin and growth hormone, you must remember that. Some drugs which are dopamine receptor antagonists like phenothiazine, metoclopramide, oral contraceptives, estrogens, tricyclic antidepressants, verapamil, ranitidine, SSRIs, paroxetine, carbamazepine can also produce an increase in prolactin. In primary hypothyroidism, TRH, which is a prolactin releasing factor, it will be elevated. Empty sella syndrome is also a cause of prolactinemia. Transient elevations, fluctuations can occur in serum prolactin levels following 80% of generalized motor or complex partial and some 15% of simple partial seizures. Peak levels are reached in 15 to 20 minutes and return to baseline over the subsequent hour. So having a seizure can also increase prolactin levels. Any breast or chest wall trauma or surgery can raise it approximately 50 nanogram per ml. Excessive exercise can also raise it. Stress can raise prolactin, as in the case of anorexia nervosa. Sometimes it can be ectopic. For example, in renal cell or hepatocellular tumors, uterine fibroids, and lymphomas, there is ectopic secretion of prolactin. Infiltrating hypothalamic tumors will obviously lead to a decrease in dopamine and an increase in prolactin. Renal failure and cirrhosis can also lead to a raised prolactin level. So, these are the differentials of a raised prolactin level. The main thing that you have to get from all of this discussion is that if you see a very large tumor, but it has only elevated the prolactin mildly, then this means that it is a Stolk effect. This is not a prolactinoma. Because you see, prolactinomas have to be managed medically. But if the prolactin is not elevated that much and you see a big tumor in the pituitary area, then it means that you don't have to give medication, you have to treat it surgically. As large prolactinomas usually have a very high prolactin level. The bigger the tumor, the more the prolactinoma prolactin level. And if there is persistent post-op prolactin level and the elevation is still there, then it can occur with even tumor removal if you have totally removed it because of the result of stalk injury. Sometimes up to 90 nanogram per ml, stalk effect is doubtful if prolactin is more than 150. And for stalk effect, just follow these patients. Do not use bromocriptine. I have made this slide. You can